Hi there, and thank you for joining us. Today's COVID Weekly Roundup, presented to you by the California Association of Health Facilities. Today is April 10th, 2020. We're going to cover some information that was sent out to this week to the providers, and we'll go over that. Each week we'll do these series to kind of recap what has happened during the week, and we'll try to forecast what we see for the week coming. With us today, we have a guest speaker, Dr. Nemily Stone. Dr. Stone is a medical epidemiologist for the Long-Term Care Division for Healthcare Quality Promotion at the Centers for Disease Control and Prevention. Well, that's a mouthful. And she's going to talk to us because her team has been embedded with a number of facilities that have had outbreaks, COVID outbreaks, and she could talk specifically to best practices and strategies that she knows that are working effectively to contain this and keep the rest of our buildings safe. So we'll get to Dr. Stone in a second here. I just want to go over some of the stuff that we learned this week that we know. And just to recap, this AFL came out from Department of Public Health last week, and it caused a ton of consternation. There is slightly conflicting guidance between what that says and what CMS has requested. And CMS issued guidance for long-term care last Sunday night, or was it last Thursday night, I'm sorry. And then we mentioned it briefly on the call last week, but I want to talk about some of the issues that CMS has identified, because it's spelled out a little bit easier for us to follow in my respect, if you look at the guidance on that link there. So there's a PDF there that you guys should take off or print off and take a look at. It has lots of great strategies. It puts it into kind of a 5-part series of things that you should be doing. So I want to just cover some of the highlights that are really important that will help us continue to protect our residents. So one of the things, if you've not already started doing this, I assume most folks have done this and have a process to do this, to document this, but every resident should be assessed for symptoms and have their temperature checked every day. And for the duration of the state of emergency, all long-term care personnel should wear a face mask while they're in the facility. Now, I realize when we say that, you go, oh, well, that's fantastic. I've got 100 surgical masks to last me for the next month. How am I supposed to do that? These are recommendations, and I think they understand that there's just not supply out there to make it a mandate. But if there was supply out there, they would mandate it. So if you have the capacity or the ability to do this, that's a best practice that we should be incorporating right away. If COVID transmission does occur in your facility, everybody in the facility should wear full PPE irrespective of the COVID-19 diagnosis. Now that's what CMS requests or recommends. Like I said, this is all based on whether you can actually accomplish it. And that may be difficult for you to do. There may be some other ways that are easier for you to control COVID-19 in the building, and we'll talk about those environmental controls and staffing and things like that. So we also know that CMS really wants to make sure, and I think everybody's in unison here, we want to make sure that any units that you have designated for COVID positive folks and taking care of those folks needs to be able to maintain the strictest of infection control practices. And then this last little bullet point was something new, because we've not normally done this, but CMS has recommended that health departments, hospitals, and the associations that represent nursing homes would work together to ensure coordination among the facilities. So when that happens, when CMS makes a request, our ask of public health was for us to integrate into their command center so that we could help coordinate movement into facilities that had self-identified with the ability to maintain those strict engineering controls. They had staff and PPE to manage COVID positive people. Since the state has essentially deferred kind of the coordinated control of this to the local health departments, it's made it very difficult for us as CAF, meaning to help the Department of Public Health gather great information about how our facilities can help. So I know we've sent out a ton of surveys, and you guys are probably getting tired of hearing from your local public health, your local licensing office, us, and anybody else who may be asking you what's going on in your facility and how prepared you are, and do you have adequate staff, and do you have PPE? I realize that becomes burdensome to answer those questions, but we really want you to focus on the things that are going to impact patient care. And when we ask those surveys, especially if it revolves around staffing, I know that public health in a very short period of time is going to call every facility in the state to ask them about their staffing and what their current situation is, and to project what positions you may possibly need in order to maintain operations. We want you to understand that this is not a gotcha moment. This is a moment where we all have to come together. Us, the regulators, the epidemiologists, the local public health departments, we've all got to figure out a way to do this and do it in a manner that's going to be as safe as possible for the remainder of the folks that are in our building. We've talked to a number of providers about how they do this, and there are some good success stories, both about facilities that have taken wings and wards and dedicated them for COVID treatment, but also facilities that have learned of a COVID positive patient in their building and were able to maintain it from spreading. So there are some good, there are some paths to success. So I don't want you guys to get scared that this is impossible for you to do. I think Jocelyn had a great mission or a great message on the last webinar. You guys have got this. You really do. You know how to deal with this. I think there's a ton of fear, and that fear leads to us overlooking some of the things that we can do to manage this. So, and that's a part of why we asked Dr. Stone to join us today, because she's going to go over some of that stuff as well. So for staffing, I know a number of you guys have seen the story in the news. I hit national news about the facility in Riverside County that had to be evacuated due to no staffing. This is definitely an area of concern, not just for us, but for the state and the governor's office. And that is why every facility is going to be contacted about staffing. What we don't see in the news is there are a number of other facilities that are in very similar boats where they've had an outbreak and they have multiple staff that have tested positive that can't work, and they have multiple staff held out under investigation. In those instances, the counties have been coordinating support, or we've been getting registry or any other method that we can get these folks into the buildings. I just want you to know that that issue is very real, and it could potentially happen to any one of us. And if it does, and when it does, the procedure to ask for help is to call public health immediately. Well, obviously, when you get an outbreak, you get one positive test or one suspicious test. We want you, or a person under suspension, we want you to notify the local public health department. These are not folks looking to come out and ding you for infection control. These are folks that want to help you protect the folks in the building that don't have COVID. They want to teach you how to do that. They want to make sure that your donning and doffing procedures are correct. They want to make sure that your staff have been fit tested. They want to make sure that you're implementing those engineering controls and strictly monitoring your healthcare workers for signs and symptoms. All of those things you need to address at the time, and that will help. But if you get to the point where you're about to evacuate, or you anticipate the need maybe in a day or two, if you're looking at, I have nobody for my knock shift on Saturday night. If you're looking at, I have nobody for my evening shift on next Thursday, start addressing those staffing shortages now. If you need assistance, don't hesitate, reach out to us. I don't have a staff of nurses to go out and help people. All I can do is make a call to the state to get somebody in there immediately. But what we don't want you to do is we don't want to evacuate a facility, simply because it dramatically exacerbates the problem, because now we have unknown or suspected COVID folks going into other presumably COVID naive buildings. And now we have to worry about transmission into those buildings. And when we evacuate a nursing home, there are no other places for these folks to go. It's either into other nursing homes or it's into an acute care hospital. The field medical sites, the alternate care sites are not set up to deal with our types of residents. So when they get evacuated and they go to a field medical site, they're sitting on cots and they don't have the staff to deal with that. So this is not an ideal situation. We want to, whatever we can do, we want to keep those folks in the building. So with that being said, please, this is extraordinarily important. Could have long-lasting impacts for the people that are in your building if you have to evacuate them. So we want to know that stuff immediately. And please reach out and call everybody you can for help. Nobody is here looking to get you for anything. Now, on the back end, we can talk about that, but in order to protect the folks in the building, I want you to just jump to life-saving measures immediately and worry about the stuff that's a little less acute to deal with immediately. Don't let your fear of contacting public health stop you from reaching out to ask for help. So outside staffing resources, not very, they're not in an abundance. In many counties, they have essentially gone to, like if you're sending a staffing resource request into the county, they're giving you a list of registries that you can hire folks from. At this point, that's what we're looking at. We do know that a best practice many operators had identified was to have a increase pay for their existing staff. And then we're working on the voucher program, which I know many of you guys saw. The governor gave his press conference about the housing vouchers for healthcare workers. As soon as we get a word on the operational capacity, like how you get the vouchers, what hotels they can stay at, we'll pass that out immediately. We'll send it out by magnet mail and also put a note on the forum to tell you how to access those resources, because I know a number of providers have identified that if they had housing close to where their building was, that they could keep staff working for longer. Plus, it might be a safe place if you have them working COVID positive patients, so they don't feel fearful of taking this back to their families when they go home. Okay, so we have talked about this. I just want to reiterate what this is, because many of the infection control surveys that we have seen, not all of them, some of them have been fantastic, really, But some of them have identified the donning and doffing procedures are not being done correctly, which could potentially cause an exposure risk. So for those that are not familiar with what transmission-based precautions are, these are the physical items that CDC recommends you wear. CDC has a video on their YouTube website about donning and doffing that you're more than welcome to watch. I watched the video, it's not very long, it's like 10 minutes. And it covers all of these items here. So I think whoever is doing your fit testing or training your staff how to don and doff, take a look at those, make sure that the staff are following those procedures set aside in that video. All right, and so I think Dr. Stone can talk about this physical space, but we know that you know, there are many points of ways that this could transmit from a non-COVID person or from a COVID positive person to a non-COVID positive person. And so to the extent that we can limit the exposure, even internally, we will stand a much better chance of success. So when we look at the infection control and patient placement guidance from CDC, it talks about, you know, having a specific space. And I talked about this on the webinar last week, but if you have a building that's like a wheel and spoke model, you know, think about designating one of those spokes. If your building has multiple smoke compartments, maybe look at defining that by your smoke compartment. If we have identified a number of facilities that have raised their hands and said, we will go COVID positive. We will take the entire COVID positive facility or make the whole facility just for the treatment of COVID positive people. And I think that's probably a best practice. Obviously, if we do that, we're not going to expose anybody else. The problem with that is, in order to clear that space, we either have to have an empty building to start with, or we have to move people out of one building to clear the space. And so what's happening, what we're seeing, as sad as this is that in areas where a facility may have a major outbreak and they could have a significant number of people that were identified COVID positive, for those buildings, it may be easier for us to look at getting the non-COVID people out if we could test them and if we can get them into a facility which has a transitional space to monitor for symptoms before they put them, cohort them with the remainder of the folks in the building. And those are all things that we're talking about it as a best practice. I know there are a number of individual companies that have gone to this practice of defining a space for all admissions and all readmissions into their building, and they're using that space for all admissions to monitor them for symptoms. Since we don't have widespread testing of these admissions and readmissions back into our building, I think it's prudent to you know, treat those folks with precautions and monitor them for symptoms. That is a part of the recommended guidance from CDC. If you have the space and you have the PPE and you have the staff dedicated to do it, I highly recommend that as a way of at least providing a buffer before putting people in that you are unsure of with people that you know are not symptomatic. So that's kind of what it is with physical space. I know it requires you guys to kind of read some of this stuff and determine whether you can accomplish it at your individual facility. But now is the time to do it. If you're in Los Angeles County, Riverside County, San Bernardino County, Santa Clara County, San Mateo County, Contra Costa, Alameda, all of those counties have a pretty acute need for patient placement right now. And I know this has kind of been run by each individual county, and it's made it difficult for us to advise you of what to do for your specific county. We are trying to engage each county and get them to agree to do like an all provider call once a week for everybody in their jurisdiction. I don't know how successful we are going to be to try to get them to do it, but if your county, if through contact with your local public health department, they have identified they're doing provider calls or they're asking you for bed placement, now is the time to integrate with them and ask them what the capacity they're going to need is. I don't want you to clear out an entire wing of a building if the county doesn't have a need for it. So don't do it in a vacuum, but do it in consultation with your local public health department. Some of them have been very contentious. Some of them have threatened forced placement. I want you to understand that they're in an extraordinarily difficult position in that they don't have a good solution for the post-acute treatment of these COVID positive people, and that skilled nursing facilities play an integral part in the continuum of care. And to that extent, if we can safely do it and protect our other residents, let's raise our hand and be heroes in this response. And I really think that's what you guys are. Even if that's not the story that's told on the news, we know different. All right. So before I get to the final thing, I want to invite Dr. Stone to come on and talk about kind of her experience and what she's seen in facilities that have had outbreaks, and maybe some good ideas for how we go forward and what to do when this actually happens. Dr. Stone?
Thank you, Jason. I really, really appreciate the invitation from you and the team at CAS to be able to speak with your members and share a little bit of the lessons and experiences that my team has been able to have over the last week. I have to also thank my colleagues at the California Department of Public Health, the local health departments in the Southern California region, and my CDC field team, who have all been working together closely to support the long-term care provider community, your residents, families, and staff, along with many of the partners like CAF, to prepare for and respond to COVID-19 illnesses and outbreaks. We've had a team now really kind of with two goals, two missions. We're in a community where there are active COVID outbreaks in long-term care in primarily nursing homes and assisted living facilities. But as with many places around the country and around the state, there are still a lot of centers that have not been exposed to COVID cases yet. So I feel like, Jason, I kind of don't have to talk about as much because of all the great messaging you've already done around preparedness. It was almost like, I got the same script. But let's think a little bit about preparedness. And then I'll share, if there's time, a little bit of what I think is extremely exciting work that we've been able to do here. Again, in coordination with the local health department, local partners, the provider community, we have had the privilege of working with a handful of nursing home providers who have leaned forward into this preparedness, expressed interest in potentially being able to receive COVID-19 positive patients, either from other centers or from hospital discharge, if the needs increase in the community, and certainly if hospital capacity becomes an issue. And we have seen examples in other locations around the country where this has become a crush, and it is a very difficult thing to do when there's already a crisis. And I think we should really take advantage as in as many places as possible of getting prepared now. So I think to sort of echo many of the things that Jason also said, anticipate now what are the vulnerabilities in your center and make a plan to deal with it. Evaluate your staffing models now. We know staffing shortages because of illness, because of absenteeism, because of fear, because there may be restrictions on or decisions made by healthcare workers to not work in multiple centers. There are many forces that could impact your staffing, and in some centers, staffing is already weak even on a regular day. And so when you think about COVID care and the level of acuity and the risk of rapid clinical decline that can happen among residents, certainly frail, older residents with many comorbidities, you can't run a short-staffed building and be successful. So some strategies that we've talked about are within multi-facility provider organizations. If there's a building that was willing to explore becoming a COVID designated center for their organization or for their community, there may be volunteers in other centers in your organization that would be willing to step up and be a part of that. And there may be ways that staff that are fearful of working in that environment, despite all the preparedness, all of the steps that would be put into place to protect everybody, staff and residents, then perhaps they go and work somewhere else in the short term while others are coming forward to help. So the other thing that I want to put out there for you to start thinking about now is, can your staff become more localized, if you will, to specific units? Can we shut down the way our staff float all over our buildings? And it's basically consistent assignment, right? I mean, that's already something that a lot of providers are striving to do. But the reason I think it's important, even in buildings that don't have COVID yet, is as you've seen, healthcare workers are one of the primary vectors for introducing COVID into a center. And if you have healthcare workers that are as part of their job floating all over your building, and every day or every shift that they're on, they're working in a different spot, well, then the exposure levels are going to be substantially higher than if you've been able to narrow the locations, if you will, that your healthcare personnel, and think broadly about this. Think not just about your CNAs and your LVNs and your RNs. Think about your housekeeping and environmental services staff as well. Can they divide up the buildings, divide up the units in a way that is feasible but is strategic? Even before COVID's around, do this now, and it may pay dividends later. Keeping COVID out has been a very strong, consistent message for many weeks. I've seen great examples of providers implementing early on in this experience visitor restrictions, thoughtfully reducing non-essential services, things like elective consultations, the utilization of telehealth, which I think is becoming a more and more feasible option, and minimizing even the frequency of visits. So somebody who used to come weekly, say, you say check in every week by phone, and if there's a concern, have them come. But if there isn't, then just keep going with what you're doing, and then you have an ongoing dialogue with those consultants and services. I've heard of people who usually have routine diagnostic labs and things like that, just stopping all of that for now, which is a totally appropriate decision to make, as long as it's not going to jeopardize the safety or clinical care of your residents. And then screening all healthcare personnel, not just direct care staff. I think we've gotten much better at this, but I can tell you some stories where early on there were buildings that were only thinking about nursing staff and maybe rehab therapy staff, people that they immediately considered interacting directly with residents, and forgot completely about their environmental services colleagues. And this is more prone to happen if there are contract teams, contract service providers that are doing that, because somehow we forget that they're part of our team and they're part of our facility operations. But you can't, because those folks are just as critical, and it's just as important that they stay healthy as well. And many of them will be on all of your direct care units and in the rooms doing their part to clean the surfaces and reduce the environmental contamination of not just COVID, but multi-drug resistant organisms and all the usual things that we should be thinking about. So keeping that in mind, and along the lines of how do you respond to people who have symptoms or have illness, we've got to do a good job of being supportive when people are sick. There's a ton of financial vulnerability in the nursing home workforce and the long-term care workforce. People work multiple jobs because they can't earn a living wage with just one. And for similar reasons, they're inclined to come to work sick because they are going to lose money if they're not there, or they're going to lose vacation days, or there have been occurrences where people are threatened with their jobs if they don't come in. And those kinds of behaviors just do nothing but put everyone at harm's way. And so we have to, as a community of providers, reassess how we support the front line and keep them healthy, well, and feeling supported in this time of extraordinary anxiety and vulnerability. Identifying infections early, many of the providers we've met with are doing resident monitoring of vital signs, pulse oximetry, and screening for signs and symptoms of respiratory illness or other change in condition. Q-shift. Even buildings that don't have COVID have moved to that frequency, although others are still kind of doing it daily. I think it's an important conversation with your team. Have a low threshold for implementing precautions if you think that there's a resident who's exhibiting illness. Maybe it's not a high spiking fever, maybe it's just a low grade couple of temperatures. But remember that the frail and older adult population does not always manifest infection the same way that a healthy, robust young adult might. So the kinds of signs and symptoms that originally were being, kind of the COVID flags, if you will, they were based on travelers and otherwise fairly healthy people. And the way that COVID manifests in nursing home residents is not the same. And that shouldn't surprise any of you, because it's true for many other infections as well. So being vigilant, constantly vigilant, having that low threshold for implementing precautions and evaluating for COVID along with all the other potential illnesses and conditions that could result in a change should be kind of part of your standing protocol. But really, I think this issue of COVID, it just raises the stakes. We have seen providers become have very strong success stories if they identify and recognize COVID or highly suspicious clinical presentations among their residents early enough. And what happens is they put them in single rooms, they implement better PPE, they minimize the numbers of healthcare workers going in and out of those rooms, and they work closely with their public health programs to get access to testing. And that has worked in a few places. And even when the diagnosis of COVID wasn't made for over a week, there were still, at least knock on wood, after, this is now a couple of weeks since that exposure, the initial case in that building, they have had no healthcare workers infected and no clinical illness among their residents. So it can be done, just as Jason said. And I think we have to have that trust in our teams and ourselves, and do this well, do this right. The basic infection prevention practices that prevent the spread of COVID-19 are the same that you've heard CDC and other public health partners talk about for all the other organisms out there, Clostridium difficile and multi-drug resistant organisms, Candida auris, carbapenemase producing gram-negatives, all these resistant bacteria. It's hand hygiene. Imagine that. It's hand hygiene. It's cleaning and disinfection of equipment and environmental surfaces. And then it's transmission-based precautions, which Jason alluded to already, which has a few components. One of them is the placement of people. You know, single rooms are the best option. It minimizes exposure not just to healthcare workers, but to other residents. If you are strapped for single rooms, which many places are, then cohorting individuals can work, just being wary of the fact that sometimes, you know, you might put people with similar symptoms together when they may not have the same process. So this issue, or this idea of designating space for COVID care, is a really smart strategy. And again, if you're leaning forward into your preparations, then you're not in a crisis right now. You have the time to walk around your building and think about the space, think about how you could move and create kind of some separate area of care that would enable you to kind of quickly isolate potential infected people away from the rest of the resident population, and then dedicating staff to care for those individuals while their evaluation is happening also minimizes exposure to the rest of your staff. So these are the strategies, the thoughtful ways that providers can protect themselves and protect their residents. The other option that I think is worth thinking about as we're talking about space is designating space for COVID unknown residents, perhaps people who are exposed or you're concerned and you need to monitor them more closely, wait for a test, or recent admissions. You know, this idea of an observation unit or a transitional space that's, again, separate from the rest of your resident population. It keeps you from scattering people who are new admissions all over the building. It creates an environment that's a little bit separate and gives everybody a little sense of security, that there's a bunch of different controls being put into place to minimize, again, the potential for spread. There are a lot of issues with PPE supply chains, disruptions, and getting disinfectants. People have trouble getting alcohol-based hand rubs, refills. All of these things we know are huge, real challenges that you're facing. I don't have great solutions, but I will say that there are a lot of strategies for conserving PPE supply, extending the use of your equipment in a way that's safe, but that does enable you to not burn as much as quickly as people probably do when they're not being mindful. So I will perhaps send, Jason, I'll send you a list of resources from our website that you can disseminate to your members, and then people can take a look at those links and see kind of where those resources and strategies are outlined on our website.
Yeah, and we've got a link to that that exact page that talks about the extended use of PPE, and on the very first slide of our presentation, it had that link. For those that weren't attuned, just go to the CAF.org. There's a big red banner that says COVID information. We've broken down our coronavirus website into sections. So we will have a section for CDPH's most recent communications, CDC's guidance, CMS's guidance, our National Association's guidance, as well as the Cal OSHA requirements for reporting workplace injuries, death and illness. There is a number of stuff on there. I realize it's like information overload for you guys, but
it sounds a little overwhelming. I'm feeling overwhelmed listening to you, but on the other hand, It's
Yeah.
a great
So
clearinghouse, clearly a one-stop shop for people, and you should be taking advantage of all of those resources. So many of your colleagues are thoughtfully trying to put out information to make you successful, and you should take advantage of it. So let me just highlight a few things that our team has been able to do. We came almost a week ago, and really to support the state and the local health departments in response to COVID outbreaks, and really help create some processes for outreach to nursing homes and assisted living, doing some risk assessments, and then for facilities that were higher risk, actually doing either remote or on-site infection control visits and assessments and visits, and talking through what's the situation on the ground, what are requests for testing or PPE supply concerns, or requests for additional education. The other piece that I think I alluded to that's been really fun for us is being able to explore partnerships and strategies for engaging the nursing home community in this preparedness activity, and really identifying volunteers that are willing to have a conversation about designating an area and a team that could be involved in COVID-19 care. TAF and some of the regional Medicaid managed care providers and the state HAI prevention program, all of these folks, in addition to the local health department teams, have been kind of working in concert. And the advantage, frankly, of being involved in those discussions means that, you know, if you're a designated center, you're very high on the priority list for getting local resources, because you're providing a service not just for your residents, but for the community at large. Some of the things that I've really learned from these visits and conversations with your colleagues over the last few days is the incredible commitment I've seen among facility administrators and DONs and the clinical and administrative leadership of the buildings, like incredible commitment to their teams, and a real concern for being able to do something like this in a way that is safe and that is, can allay some of the panic and anxiety that we're seeing among frontline staff. My feeling about it is I'd far rather know that I have taken the time, prepared my team, gotten the right supplies, and created a process and a plan for accepting someone with COVID into my care than have it just pop into my building unexpected. You know, there's just two ways that this can happen, and I think it's a lot safer if you do it in the controlled, prepared way. I can't tell you how many nursing homes and assisted living facilities across the community will be affected by COVID, but if it does surge and circulate widely in the community, I suspect most providers will be impacted in some way. So again, I would just implore all of you to act now and do these things now, think about them now, work with your local and state health departments now to get as much help as you can to do it right, and get on those lists and be known entities to those public health partners, because they're the ones that will be working with hospital systems and EMS transport systems and making decisions for the community and the good of the community, and you'd rather be a part of that discussion than left out. So I'm going to stop there, I think, and just close by saying how much I appreciate this opportunity to hear some of your thoughts on this and hear some questions, but also just an incredible shout out to the many, many providers who have been so welcoming and thoughtful and fun to meet, and see some wonderful, wonderful healthcare facilities in this community. You should be proud of your colleagues, and try to challenge yourself to do something similar in your community. Thanks, Jason.
Thank you. Yeah, thank you so much. Your work out here has been outstanding. What the folks on the webinar don't know is that I've talked to a number of providers where you and your team have gone out on site and helped those folks. And every one of the providers said that this was a wonderful service, and they left feeling totally confident in their ability to manage these events. So when Dr. Stone talks about, that proactive approach to engaging your local public health, one of those things I would suggest is, if they're early in their planning process, they may have resources to help you do things like Dr. Stone's team did. Now, it may not be available in every community, but I've talked to a number of health departments that have expressed desire to go out and assist people proactively. And if that meant getting an infection preventionist from an acute to help go over this stuff, it's maybe to help your staff with donning and doffing. If you've not been fit tested, there's some Cal OSHA local offices that are willing to come out and do that on site. There are a lot of resources out there for you to help. My suggestion is to engage with those folks at the local health department immediately. So we know we've talked about healthcare coalitions, ad nauseum for the last 3 years. Hopefully you guys have built those relationships within that healthcare coalition so that you can just pick up the phone and you know the person already. But if you haven't, don't let that stop you from reaching out and asking for help, because I'll just give you an indication. Currently, we have 191 skilled nursing facilities in the state of California with at least one COVID positive person in them. So that's about what, a 20% of the current number of buildings. So, and we're still early in this. So my recommendation is not to think that this is going to bypass you just because your community is not currently experiencing a surge. It's time to have this written out. You have the plan in your head of how you're going to do this. You've talked to your staff. You've identified who's on board with helping these folks. I really think the best practice is to have a transitional space to monitor all incoming admissions. If you can do it, I would start on that immediately. I would be very cautious about that. We're still unsure of asymptomatic or pre-symptomatic transmission, and to the extent possible, we want to protect ourselves from that. So, Courtney, maybe you can go through the some of the questions and weed out the questions for us. And
yes, I'm here. Can you hear me?
Yep.
Okay, great. So our first question from earlier, we had a question from Jared, and he wants to know, are cloth, quote, homemade masks acceptable for direct care employees? This would greatly help me preserve my supply for use should we have a COVID positive resident come into my facility.
Well, I can talk about the recommendation from CDC is to have a surgical mask, but they understand that you can't meet that. They haven't made it a mandatory because they understand folks can't meet that need. That's why it's guidance. So I mean, I could defer to Dr. Stone, but in reality, you just got to do the best you can with what you have. I would say that anybody in patient care should use the most, if you can afford it, if you can get the supplies, that's the best practice. Anything outside of that is, I don't know, maybe Dr. Stone could talk about the efficacy of a cloth mask versus a surgical mask, but I always take the most cautious approach. And there's a reason why they made those recommendations for that specific thing. Dr. Stone, do you have anything else on that?
No, I would agree with exactly what you said. You know, um, there sort of there's protection, there's PPE for protection, and then there's PPE for what we call respiratory hygiene and cough etiquette, which is like the, you know, cover your cough, cough in your elbow, clean your hands frequently. Well, source control in that context is wearing a mask in order to protect the rest of the people around you from you. So if I've got, you know, sneezing fit from my allergies in the springtime, it's less alarming and better for everyone if I have something covering my face. It reduces the potential exposure to everyone around me. So those, you know, a lot of the recommendations coming about, you know, universal face masks and not just in healthcare, but in communities in some places are directed for source control purposes.
Okay. Yeah, our next question comes from Faye. So for 14 days, for the 14-day quarantine rule, does this apply to all admissions in the nursing home coming from an acute hospital with no COVID-19?
Well, I think the guidance is that for widespread community-based transmission is to treat every admission as a suspect case. Now, it depends on how long they were in the hospital. Were they in the hospital on transmission-based precautions for 10 days? And if they were, then that reduces the amount of time that we theoretically need to oversee them. Now, if they were in a hospital without transmission-based precautions, then we would want to monitor them for whatever the 14 days is from the day that they come in.
Okay,
Yeah, I think that's right. And just to add on to that answer from Jason, it's becoming more and more apparent as we learn and gain experience caring for communities and individuals with COVID-19 that there can be very minimally symptomatic individuals, sometimes people who have really no reported symptoms that can be capable of shedding virus, infected and shedding virus even at low levels. There's a window of time from when we are exposed to before we develop symptoms where we may start to shed virus before those symptoms begin. And it's for all those reasons that this idea of a 14-day observation period is recommended.
Yeah, and just as a reminder, I know we've harped on this, but those environmental controls, the hand washing procedures, all of these things need to be. It's a 24/7. We never take a break. We're always on top of it. This is what we do, and we don't do anything different. It's all the time, and no lapses. In infection control, we don't do any of that. We try to keep this as consistent as possible, and that's why it's important for you to cover this stuff with your staff. I think by giving them the information and the knowledge to do this correctly, I think will empower them and make them feel a little safer to take these tasks.
So we have another question that kind of dovetails with that. So Darla is asking, if a patient in the hospital is in a COVID monitoring site, should they still be tested prior to discharging to a skilled nursing facility?
Well, if the county or the local health department has the capacity to do the testing, our recommendation to all of the local health departments and the CDPH's recommendation is to prioritize testing of any admission and readmission back to a skilled nursing facility. We realize that's at this point, it's kind of pie in the sky because the health departments might not have enough testing to meet that need, but to the extent possible, we want to encourage them to test every single person before they come in. I know that's we're still a little ways away from that, But until we do that, I really feel pretty strongly about making sure that we keep these folks in a spot where we can monitor them for symptoms. We've had a number of these cases where pre-symptomatic transmission has occurred with folks coming from the hospital that have not been tested, which then in turn caused an outbreak in the facility. That has actually happened. And so we also know that staff have been either asymptomatic or pre-symptomatic and have also caused outbreaks to happen in facilities. So we have to take this pretty seriously when we talk about monitoring those. But I think it's way easier once you know where the COVID positive folks are to take care of those people. It's the unknown that is causing the problem. And that's where we're finding some of these large scale outbreaks.
Okay, so continuing with that thread, do we still need to put residents in a separate unit if they had a COVID-19 test in acute with a negative result?
Well, they've got a negative result. Did they have symptoms? And so if they've had symptoms, you've got to follow the guidance for when to take them off precautions based on their symptoms. Is that correct, Dr. Stone?
Yeah, so it's a little bit of a tricky decision. It is true that when we talk about discontinuing precautions, if you look at the current guidance, that was very conservative, in terms of the trying to be kind of the safest option as possible if it's feasible, which again, I agree 100% that the capacity of testing and the feasibility of following some of the ideal case guidance is very hard. But 2 negatives is preferred only for the, concern about sensitivity of a test, meaning how well will it detect the organism that you're looking for. And there are some, this isn't 100%, it's very good. And I would feel reassured, but I would still be vigilant. And I agree also with what you're saying, Jason, about what's the context in which this test is negative. Was it somebody who was never symptomatic and, happened to get a test? Or was it somebody who had symptoms of, that were concerning enough to send a test? And was there any alternative explanation identified for why those symptoms occurred? So there's some other pieces of information that would be helpful to know how to handle that individual.
And Courtney, before you hop to the next question, I want to answer this because somebody submitted this question before we started. And they had asked to please address to the providers what indemnification from the state or federal government will be in place to handle the increased acuity and perceived mistakes a provider may make in the disaster and managing care. And those are great questions, ones that not only are we concerned about, but the California Medical Association, the California Hospital Association are equally concerned about. There is a great deal of fear out there about what our liability exposure is as independent business owners. That fear, unfortunately, I don't have a great answer for that yet. We are actively working. We've been on conversations with General Counsel for Health and Human Services, the Governor's Office, California Department of Public Health, and both us, the Hospital Association, and the California Medical Association have provided the state with a framework for legal immunity for the care of these folks. So we're working on that. We anticipate that everybody in the healthcare continuum is looking for this exact thing, and I'm hopeful that we'll be successful. but I can't guarantee we're going to get it, but we're definitely working on it. And I know tons of people are really concerned about that. So I wanted to address it before we got off the call. We are right at 2 o'clock, guys, and I want to be respectful of people's time, especially our esteemed guests. So if you have questions, we have a website or an email address which you can go to ask questions, and that that email address is monitored. And then what we'll do is we'll take your request and divide it up to the staff member who's assigned for the types of questions you have. So we have somebody for staffing and workforce issues, we have somebody for regulatory issues, somebody for clinical issues, and somebody for emergency management issues. So if you ever have questions about resources, we will try to collect everything and put it in one clearinghouse on that page that you see listed there. And then all of our training videos are on our YouTube page there as well. So with that, I want to say thank you very much to our guest, and thank you very much for joining us, and we will see you again next week.